Heart disease doesn't always look the same in women as it does in men, and that difference matters. Today on Healthy Conversations, we're joined by Dr. Priyadarshni from the Heart Center to talk about women and heart disease. What's different, what symptoms women often miss, and why heart disease remains the leading cause of death for women. This is an important conversation for our community, and we're glad you're joining us. So thank you, Dr. Priya, for being here today and joining us. I know it's hard to get out of the office sometimes, but we appreciate it so much. And, it's February, heart awareness, and especially women. So we wanted to have you on here to kind of just talk about that. But before we get started, kind of tell us a little bit about your role at the Heart Center and kind of what brought you to Athens, Alabama.
Yeah, thank you for inviting me to this podcast. I am a non-invasive cardiologist, general cardiologist. I basically take care of everything in cardiology, and then I refer to subspecialties if needed. Like, for example, if a patient needs a stent, I would refer you to Huntsville Hospital, Maine, and then you would come and follow up with me. That's my job. I focus on prevention. I focus on coronary artery disease, heart failure, arrhythmias, everything in cardiology, basically.
Well, I just love your heart sweater. It's
Thank
all
you.
appropriate for right now. So,
Thank you.
but coming to Athens, what brought you to Athens?
So I was looking for a job and I did my training from University of Texas medical branch. I wanted to stay somewhere little bit warmer, not go super cold. And then when I interviewed here, I loved the people. Honestly, that was the reason I chose to come here.
Okay, well, great. Well, if you've not experienced a full summer yet, let us know what you think about that warmer temperature when that gets here. But no, we love it. We're so glad that you came to join us. So, kind of from your experience, just kind of starting us off, what's one of the biggest misconceptions that you frequently come across regarding women and heart health?
Well, the biggest misconception is that heart disease is a man's disease. It doesn't occur that frequently in women. That's the biggest misconception. Heart disease is number one cause of mortality in United States in men and women. So a lot of women do not know about it. They think breast cancer or other type of cancer are the common causes of mortality in women, but it's not. It's heart disease. Yeah.
So, Dr. Priya, why do women tend to be more underdiagnosed or diagnosed later than men?
So it's multifactorial. There is multiple components to it. First, as a woman, when we have symptoms, we tend to put that to attribute to anxiety or other causes than to actually think that, as I said, women do not think that the number one cause of death in women is heart disease. So the lack of education overall in the population matters. um, it's underdiagnosed by physicians as well, and it's a subconscious bias. It's not something, physicians do it consciously, but women's symptoms can be atypical. Chest pain is still the main symptom of heart disease in women, but then women also tend to have indigestion, jaw pain, chest pressure, um, back pain, radiating between your shoulder blades, things like that, fatigue, tiredness, excessive tiredness, all that can be one of the symptoms of heart disease. And then the other factor is just, overall awareness that this disease is so common in women. Yeah.
Absolutely.
Yeah, you go through that list, and I can kind of go, check.
I have
Check.
that. I have that.
Excessive tiredness, you do,
But
because I can see how
yeah.
you do
Yeah. So
miss those things.
So this is what I say. You can have indigestion, right? A lot of people have it. And that necessarily does not mean heart disease, but you're having indigestion, which is way out of what you've been experiencing. And then if you think that, you haven't changed your dietary habits, you haven't done anything different, then you should, reach out to a cardiologist. Yeah.
Absolutely. I think you touched on it a little bit there, but how have traditional views of heart disease kind of affected that gap in healthcare?
Right. So traditional views of heart disease is that, women gets heart disease lesser compared to men. Women tend to have heart disease later in their life. While that is true, but at the same time, the younger women also can have heart disease. And that's where the symptoms could be atypical or the symptoms are not as profound as in men. And that's something to, just be aware of. Yeah.
Absolutely.
Okay, so are there any other symptoms women have that aren't classic symptoms that men don't have?
Right. So I always ask in my clinic, and it's a detailed questionnaire. But um, as I said, chest pain, number one symptom in both men and women. But women can have their symptoms are more triggered usually by emotion or mental stress compared to men, where the symptoms are more triggered by physical exertion. Symptoms could include nausea, could include vomiting, indigestion, epigastric pain, meaning pain in the upper belly. I always say from here to your abdomen, if you have any sort of pain, you got to talk to us about right arm pain, left arm pain, instead of chest pain, chest pressure, or just some people explain it, oh, I feel a twinge in my chest. It's very sudden, it comes and goes. All these could be symptoms of heart disease if you are having other comorbidities like hypertension, hyperlipidemia, diabetes, kidney disease. Family history is extremely important as well. If your family members have had heart disease earlier compared to, when it occurs, actually, you are at higher risk because you can have that genetics component of it as well.
Okay, so you said the right arm too, not just the left arm. I always thought it was just the left arm.
Right. So the typical pain is the left arm. It starts in your chest. It's a pressure like pain. It occurs with either emotional trigger or physical exertion. It can radiate to your left arm, your jaw, your back. That's the typical. But you could also have sometimes right arm pain, only jaw pain, only chest pressure. So a lot of symptoms, these are, we call it atypical symptoms, but it's just how the pathophysiology of heart disease is in women and men. Um, Apart from the traditional risk factors, women also have other risk factors, and that's why they tend to get these different, a whole myriad of symptoms. Yeah.
And you said genetics. So, like, does it matter which side of your family it comes from?
No, it does not. As long as your first degree relatives, or even, anyone in the family, if they have heart disease, you got to tell your doctor about it. Um, Early onset of heart disease in men is less than 55 years of age, and in the women, it's less than 65 years of age. Actually, it's 50 to 55 in men and 60 to 65 in women. So if you have it earlier than that, then yes.
Interesting. Okay. You talked about the subtle warning signs, things that might trigger it, like stress and anxiety, unlike men. Men are, you said, more physical, correct? Okay. And so when should you seek medical attention? Like, when is it like not indigestion or not anxiety? Like, how do you know the difference?
Right. So sometimes it could be very difficult, and especially if you also have, let's say, lung disease, right? So then you can feel shortness of breath, and shortness of breath could come from lung disease, or it could come from heart disease, or it could come from anything else as well. So my only advice is, first of all, know your risk factors. If you are, if you have high blood pressure, if you have high cholesterol, diabetes, family history of heart disease, chronic kidney disease, you're on dialysis. These are just some of the traditional risk factors. And I'll explain the other risk factors as well in a second. But if you have those things, know whether it's controlled or not. If you
Gotcha.
think your blood pressure has not been controlled, your diabetes has not been controlled, then, you need to seek care. And then, especially with that, if you're having all the symptoms we talked about, shortness of breath, chest pain, chest pressure, different kind of atypical symptoms, then you need to, seek attention.
Okay.
At least reach out. There is always good to reach out to your doctor and rule it out versus ignoring it and then find out later that you've had a major thing going on.
Okay. I just would hate, like, I have TMJ, and I'd hate to, like, clog up the ER because I'm like, my jaw hurts. So,
Right. So, again, if you have TMJ and you have pain because of that TMJ in your one jaw, I'm talking about pain in both jaws
oh, okay. So,
at the same time.
so
Or,
like
yeah,
both sides kind of throb, radiate,
it's
like,
usually like a sharp or like a pressure-like pain going to your jaw.
okay,
Um,
sharp pain.
Yeah, or like actually pressure more, but it could be sharp too. Again, symptoms could be deceiving, and that's why seeking, like for example, in you, I don't know your risk factors, but if you're having jaw pain, which is on exertion, or for example, it's more than what it is usual. I mean, the first recommendation would be go seek attention and see if your TMJ inflammation has worsened or if there is more something else going on there. If your jaw pain doesn't resolve there, then the next step would be, and if it's coming along with the symptoms like shortness of breath, chest pressure, chest pain, then yes, seeking medical care with a cardiologist would be appropriate.
Okay.
And jaw pain is a tricky one because, when you have jaw pain, it's like you don't know if it's your teeth or if it's your ear or if
You've
it's
been
your sinuses
grinding your
or
teeth in
it
your
could be,
sleep.
yeah,
Exactly.
grinding your teeth in your sleep. And that's a frustrating one because we use this area, so often. So I can understand how that one would be a
Yeah.
tricky one.
It is a tricky one. And as I said, it's not just one symptom, right? Heart disease, it's a lot of different symptoms together. So if you're feeling like, hey, all of a sudden so for example, in you have TMJ and everything has been stable, and all of a sudden you were exercising on a treadmill, and then all of a sudden you're starting to have something uncomfortable feeling in the chest tightness. Some people explain it, something is sitting on my chest. So that much of chest pressure or tightness, and then that tightness, I felt like it was going to my jaw, then that would be something to at least think about, cardiac disease. Again, it's this variety of symptoms together and not
Yeah, that
just one.
combination.
Yeah, the combination.
Well, in talking about risk factors, we kind of had a question that I came across. I was like, oh, well, we're going to ask that. But so how does pregnancy related conditions impact long-term health risk? That's not something I would have, we don't think about that when you're young and pregnant.
I
So
100% agree with that. And that's what I was telling you before, that we were going to talk about some of the non-traditional risk factors as well. Non-traditional risk factors, especially in women, autoimmune disease. If you have rheumatoid arthritis, you have, lupus. If you've had preeclampsia, you've had gestational diabetes, gestational hypertension or, high blood pressure. If you had a premature birth of a baby, all that contributes to future cardiovascular risk.
I've
Wow.
never heard that
Wow.
before.
Wow.
Wow.
So
Exactly.
you think with preeclampsia, you get the baby out, everything's
Goes back
great.
to normal.
Goes back to, so now it's put you in a different risk category.
Correct.
Wow.
And the reason for that is when you're having all these pregnancy related complications, your body's inflammation level is high. There is a lot of hormonal dysregulation, and all of that long term affects your heart. I always say, if you had any of, and this is one of the questions I ask in women when they come to our clinic, is that if you had one of those risk factors, first of all, go see a cardiologist in the postpartum period. That's extremely important, that after you deliver the baby, that 4 months or 4 weeks of that time is very important. If you've had diabetes, gestational diabetes, it's a good time at that 3 to 4 months window after delivery to go do a check for yourself for diabetes. If you've had high blood pressure during pregnancy, that would be the time to check your blood pressure at home and see how your blood pressure has been. Um, what happens is that gestational hypertension or gestational diabetes increases your risk of hypertension and diabetes in the future, and hence also increases your risk of cardiovascular disease. So yes,
Yeah, and knowing
those
that
are
risk factor, then if
yeah,
those symptoms start showing up, you may
yeah,
think a little bit more about it.
or even
Mhm.
prevention,
Yeah,
right?
yeah,
So,
prevention, yeah.
our guidelines say you have to be on a cholesterol medication at certain, if your LDL is that much, or there is a certain numbers there, right? Or if you're in age risk of 40 to 75, you're a diabetic or you're a smoker, you should be on a cholesterol medication. And people ask me this question, that why do you have to be on a cholesterol or a statin like medication when you don't have hyperlipidemia or high cholesterol? And are these risk factors we just talked about in women? And they're like, why should I be on a statin? And my explanation to that is we have bad cholesterol, which is LDL, and you have good cholesterol, which is HDL. But that's not it. At this point, we have a lot of other risk markers like ApoB, lipoprotein A, little a, and other things. And statins or cholesterol medication do not just reduce your LDL, but also it has an anti-inflammatory effect on the inflammation which is going on in the body because of all these premature risk factors or risk. We talked about some of the women's risk factor, which is very tailored to women as well. So I think because of all that, every patient is different and their risk is tailored to them based on what are the comorbidities that they've had. And it's very important to talk about all that.
So you said preterm birth.
Mhm.
Is that for you being preterm or having preterm birth?
I think both can be risk stressors as well, because when you are preterm, there is hormonal dysregulation in the body, and that can accelerate cardiovascular risk in you or in the baby as well. Um, Remember, this is a very common misconception as well, that we all say that, oh, we get cholesterol or LDL high when we grow older. That's not true. A baby is born with a LDL of 25. So that means LDL is a bad cholesterol. So that means when you're born at that point as well, you do have that cholesterol. What do you do with that is the environment, how you, exercise, how you take care of yourself. All that is important moving forward. And of course, the genetics as well.
Gotcha. So for women, if you have a preterm birth and you didn't have high cholesterol, high blood pressure, and things like that, is there a risk factor, or does it have to deal with the blood pressure and things like that too with your preterm birth?
Right. So I think preterm birth could be a hormonal dysregulation that can put you on a higher cardiovascular risk moving forward. I think it's not just one thing, it's always a combination of other things. And then, we talk about that in clinic, that everyone's risk is different. And then based on certain markers of, you know, cardiac markers, like, as I said, the lipoprotein little a, the high sensitivity CRP, all that can help detect if you are at higher risk of cardiovascular disease in future, and then we can tailor that risk accordingly.
Okay.
That's so interesting. Is there things that maybe a significant other or partner could be aware of or catch it before even the patient does?
In terms of cardiovascular risk,
Yes, ma'am.
so I want to touch base on the same question, a little bit of another topic as well, which is mental health. Um, a lot of us suffer from mental health. People either recognize it or do not recognize it. Some people get treated, some do not. Depression, anxiety, PTSD, all are associated. It's a vicious cycle, actually, because depression, anxiety, PTSD, among other, mental health issues actually increase your risk of cardiovascular disease in future because of the stress environment that you are going through. And once you have cardiovascular disease, that increases your risk of um, the mental health issues as well because of the whole disease you have to deal with. It sometimes can be a lot for patients. Um, Stress is one of the big contributor to cardiovascular disease that people do not realize. Stress is going to increase your heart rate, is going to increase your blood pressure, um, can cause inflammation, can cause hormonal dysregulation in body, which all leads to future cardiovascular risk.
So
Yeah.
husbands need to cause no stress.
Good answer.
I think it goes both ways.
We'll see how that goes.
I think it goes both ways. I think, we don't tend to talk much about it, but mental health overall is a very important topic and it is associated with cardiovascular disease. So trying to take care of yourself, and that's where it comes to prevention, right? What do we do about it? Exercise. There is no shortcut to that. 150 minutes of moderate exercise per week, or 70 to 75 or 80 minutes of vigorous exercise if you're doing per week is shown to reduce cardiovascular risk. I always say eating healthy, more fruits and veggies on your plate, more white meat, more fish if you're eating, you're non-vegetarian rather than the red meat. Um, no alcohol or minimize alcohol to occasions, or in our world no alcohol is good, so that's my advice. Smoking, one of the biggest risk factors. I see people using or other things like marijuana, cocaine, all that. Vaping, some people tell me, oh, I do not smoke but I vape. That still has nicotine and tobacco in it, so it is still affecting your blood pressure, your cardiovascular risk. So all that is very important.
Yeah. Well, back to the risk factors, just because this one was one I certainly hormone and menopause, kind of going from pregnancy. Now we go
Yes.
to that hormone and menopause, because I know I was telling them earlier, I had a point where I had an early hysterectomy. So, put me in menopause early. And this has been several years. So, what the doctor said then may be a little different now. But he was telling me that I needed to go on hormones to reduce my risk of cardiovascular disease because of the younger age that got thrown into menopause.
Mm-hmm. So that's a very important topic, and thank you for bringing it up. Why women get heart disease later in their life, or we say that they tend to. There are some diseases which also affect younger women, and I'll talk about it in a second. But the traditional risk factors, they are more. Women tend to get heart disease later if you talk about the traditional risk factor. The reason is estrogen. That's your protective hormone. It it's a very complex mechanism as to how it works, but it is a protective mechanism there to help
That is what he
women.
put me on.
Now, when it comes to hormone replacement therapy, there was a whole taboo going about it that hormone replacement therapy could actually cause or worsen cardiovascular disease. And the earlier trials showed that, yes, it does. And then the newer research now talk about that if you want to start hormone replacement therapy, you got to start when you're early menopause, when you're starting to have that. And then there is, of course, very fine balance as to which medications you use, what is your dose, but it seems to be somehow protective if you use it in the right way. So that's important as well.
Which means it's important to see your doctor regularly and
Yes.
have those things checked and
Yes.
followed up on.
I agree. Yes.
Yeah. Yeah. I can see that. I can see that. Well, and you've kind of already touched about the chronic stress and the autoimmune conditions that affect women's heart health. And, we're women. We kind of pull everything on our shoulders. So the stress, we we're all under
Yeah.
stress. So it is hard to kind of remember that you do have to
Yes.
kind of take care of that. Um, and I know we're fixing to talk about kind of some prevention, early actions, but one of the things I wanted to ask about was um, test like a calcium score test? I mean, maybe you can talk a little bit more about that because I know that was something that was kind of new for me, and it just happened to be something we were doing at the hospital with a new piece of equipment. So I actually had mine done.
Yes.
And so I got my score, and so I could kind of take that to my doctor and say, "Hey, here's my score," so I know where I stand with my heart, with the risk factors and stuff.
Yes.
But what are some of those?
Right. And this is a very important topic as well. Oh my God, you are bringing all the important questions. So, calcium score. Um, what is it? So when you have a soft plaque, eventually it's going to calcify in your blood vessel. And the way the calcium score works is that we, go read. It's a dedicated CT scan of your heart, and we look at how much calcium you have. We have a different kind of software which accumulates the numbers, and then you get a certain number, whether it could be 0, it could be up to 1,000 or more than 1,000, depending on what we get. Now, everyone is gonna get some calcium in their blood vessel. Not everyone, but most of us, at least, as we age, because heart disease is the number one cause of mortality, right? But the calcium score, the way it works is that, especially in the younger patient population, is that if you what we do is there is a whole software, and they compare all the people, men and women, differently in the whole United States and even abroad, and they calculate what is average calcium you should have at a certain age. So if you get more calcium than what you should have at a certain age, that increases your risk of cardiovascular disease, because it is just telling you that you've had plaque buildup going on that has calcified now, and you can see it in a CT scan. Now, there is a lot of caveats to it. So I get a lot of patients who are older, like they are in their, older is just a term.
Right.
Don't quote me on that. I
was fixing to say, what age are we fixing to talk about here?
Older is just a term, but in a way that human beings are lifespan, right? So you can age from 1 to 100 or even longer. But if you get a calcium score in a patients who are in 60s, 70s or more, you're going to see calcium, because that's how the body's natural phenomena is. As I said, you're going to have some plaques because of all the risk factors. Everyone is different, but some people cannot have anything as well, but most of them will have some calcium. It's not going to help at that point. But if you do the calcium score in younger patient populations, where in what is the actual data is less than 50 years of age, men you should have 0 calcium score. That's what it should have. You should have no calcium in your blood vessels. So if you get and for women it's 60. So if you get a calcium score in lesser than that, so less than 50 or less than 60 in women, and let's say you see a calcium score of 8 in a patient who's 30 years old, you're going to say, it's only 8. Why do I have to worry about it? It's just a small number. You said it can range from 1 to 1,000 or even more. Well, at the age of 30, you're not supposed to have even a score of 1. So that score of 8, and then we calculate based on the database, which I was explaining earlier, that based on all the men and women who've had this done and which we have the data on, and when you compare that, your risk is actually extremely high, and that needs to be controlled using good medications, control of good blood. If you have high blood pressure, then high blood pressure, exercise, eating healthy, your habits, all that needs to come in, versus a person who's in 60s or 70s and they have a calcium score of 8, their risk of cardiovascular disease would be lower compared to someone who's had calcium score of 8 at the age of 30.
Yeah. I've had my calcium score done.
Okay.
So I have several risk factors. I have high blood pressure. My cholesterol was a little off. My father and my grandfather both had heart attacks at the age of 40. So they did a blood test that showed that I was higher, I think, on something. So my doctor suggested to go get my calcium score done. And all they did is they called me back. They said, "You're fine." I don't know what my score was, but she had said if it was high, I would have to be on, I guess, a statin for the
Yeah.
rest of my life or
Right.
something like that.
Right. So I think I would suggest take that calcium score report because it's read by cardiologists and
Mhm.
discuss with the cardiologist what your risk is.
And how often should you go get that done? Like, should I?
Right. So if you have a low calcium score so again, if you have diabetes and smoking, because these are the diseases which accelerates cardiovascular disease, you're going to have calcium. So we tend not to do the calcium score in these patients because we already know we're going to see calcium. So there is no point. Or if you're on a statin. So there is a very interesting story there. How often you do calcium score? Every 5 years, 3 to 5 years. If your calcium score is low or zero, you could repeat it to see what your risk is in another 5 years. About statin, statin is just one thing. There is other risk factors we need to control. But yes, so it's recommended by our guidelines, ACC/AHA guidelines, that if your calcium score is between 1 to 100, it's a shared decision making between patient and the doctor about starting statin based on other risk factors. If it is, so it could be considered, is what recommendation is. If it is more than 100, it's definitely a consideration there. Um, Statins, as I said before, it kind of stabilizes your plaques. And with statin, you tend to see more calcium as well in the blood vessel. But remember, calcified plaque is always better than soft plaque because the plaque which breaks in the blood vessel is the soft plaque because those are vulnerables. They don't have that calcium like the calcified layer on it. So if you are on a statin and let's say should we repeat your calcium score if your calcium score was 0 now? Answer is no, because you're going to have some calcium because you're on a statin and it's going to stabilizes whatever it is there and calcify it. So no. Answer is you don't need to repeat, or you can repeat and see how much difference it has caused. But mostly with statins, I would say, if you are already on a statin, then focus on the other risk factors, control the LDL better, control other biomarkers in a better way.
So once you get a calcium score, can you make it better? Or once it's there, is it always that?
Yeah, once it's there, it's always there. But can you make it? Can you stabilize it? Can you stabilize it and not make it worse? Answer is yes. You got to work on your risk factors. But can you remove that calcium, or can you have a 0 score again? Answer is no.
Gotcha.
Yeah.
And since we're talking about calcium scores, I do want to kind of clarify. You get your calcium score from a cardiac CT, right? Is that what it's called?
Correct. It's
Okay.
dedicated CT to the heart.
Okay.
Yeah.
I know we do those at Athens Limestone Hospital, but I was trying to remember if that was the correct name for the test.
Yes. So it's, CT calcium score. It actually comes as that cardiac CT calcium score. You do see calcification on the CAT scan non-dedicated to your heart as well. So let's say you had a pneumonia and you went to hospital and they did a CAT scan on you. You could see calcium if it's there in the blood vessel, but those are not, you cannot quantify it and you would not be able to. This is not a dedicated scan, so it's very difficult to say. But, if you see a lot of calcium, then we talk about symptoms at that point to see, have you had symptoms?
Yeah.
Yeah.
Well, I had a family member who had a heart attack, and 3-4 months before, he had had his normal annual visit with his doctor and his lab work and all that, and everything was clear and it was good. And when he had the heart attack, he kind of got more educated and found out more things and kind of learned about the fact that if he had had this calcium or had found out that that would have been a truer picture of what his heart health was, I guess. So I found that so interesting after that. And then, like I said, I had it done through the hospital for something we were working on. and my cholesterol had been bumping a little bit. And that was one of the things that my doctor took into account
Yes.
when she was like, well, do we do cholesterol medicine or do we not? But your cardiac score was 0, so I'll let you get away with it for a little while, but you need to exercise more to work on it,
Yeah.
So I can see where it takes
Yes. It
lots of
definitely
different things to look at.
correct. Yeah. It's again, that's why you got to see a cardiologist
Yeah.
because it's very difficult to give a message to the primary care doctors or other doctors in the community as to what to do with that calcium score. My only suggestion is if you're using calcium score, if you're using in younger patient to either guide your statin therapy or figure out a risk as to what their risk is, it's a good thing to do. But if you're doing it in patients above, as women more than 60 or men more than 50, then you're going to find calcium. So it's not going to change your, thought process much. But again, everything has to come together, whether you have symptoms, whether you have other risk factors, what are your habits, all that needs to be accounted for.
Yeah. Is that a relatively new
I was gonna ask
tool or
that,
test?
yeah.
Because I'd not really heard much about it prior
Yes.
to then a couple of years ago.
I feel like I was behind the 8 ball over here. When I was talking about that, I was like,
Yeah, I mean, as we are moving more in like prevention, right?
Right.
So that's why it's there. It's
Okay.
been a couple of years or more than that actually, but now it's more available in smaller communities and everywhere, which is a great thing. Honestly, when I was taking this job and I was told, oh, you have a CAT scan, you do calcium score, you do CT coronary angiogram, awesome. This is a good test to have.
Awesome.
So
We have them right here.
Yeah,
So
right here.
that's
That's
we
great.
also-
That's great
We
information.
also have a cardiac MRI here.
Yes, we
which
do.
I was
We
very
do.
happy about,
Yeah,
and
we
I've
do.
ordered it, and it's really good to make decision if you have that.
Yeah, because my understanding is before we had that, the wait time of getting one
Yeah,
was
extremely.
extremely long. Yeah. So the imaging department does a great job at staying on top of some of those things that we need. So, well, I don't know about y'all, but I've learned a lot.
Me too.
Absolutely,
Yes,
yeah.
absolutely.
I've learned a lot, and we will definitely have to have you back on and probably talk about some of these things.
Oh, yes,
part
more
two.
in
sure.
depth.
Part
Yeah,
two.
part two, more in depth.
Yes.
So, I appreciate that, and I mean, heart health for women, so important to focus on during February. So, anyway, is there anything else that you kind of want to share or say that we kind of didn't touch on?
I think it was a really interactive conversation we had today. I think what I want to say is, heart disease is extremely common in women as well. Know your risk factors. Reach out to your primary care doctors, any doctor you can reach out to. And then if you think that, you need to see a cardiologist, see a cardiologist. Sometimes prevention is better than, or actually every time prevention is better than cure. So if we can catch it early and we can do something about it, then that would be great, especially in the era where we are living in, where everything is processed. We eat a lot of food, which is, on the go. We are all busy. We don't have enough time to eat healthy. And, I want to say one thing, sitting or inactivity is new smoking, is as bad as smoking. So
Wow.
get your steps in, do exercise. There is no, shortcut to that. Healthy living, healthy lifestyle will prevent cardiovascular disease. It's
Well,
as
y'all,
simple
anybody's
as that.
invited to come play pickleball with me. And get our exercise and our steps in that way. Well, thank you so much. And I'm so glad that you are here, that the Heart Center is here, and
Absolutely.
that you're now in the office with Dr. Krista Walker. I know that our growing community has needed an additional cardiologist there. So we're
Yes.
grateful to have you. Thank you so much for joining us.
Thank you for inviting me. Thank you.
Thank you, Dr. Priyadarshni, for sharing your expertise and helping our community better understand women's heart health. Conversations like this truly matter. Stay well, stay connected, and keep the healthy conversations going.